Thank you for joining us for session 1.2, Stigma in the Healthcare Setting. We have an incredible panel of clinicians and healthcare providers to discuss specifically how stigma manifests during the provision of care. I'm really pleased to welcome our moderator, Dr. Alistair Martin. He's faculty at the Massachusetts General Hospital Center for Social Justice and Health Equity at Harvard Medical School. And he's also the founder of Get Waivered, a campaign aimed at transforming emergency departments nationwide into the front door for recovery for patients with an opioid use disorder. Welcome, Dr. Martin and the rest of our panelists.
Well, thank you very much, Matthew, for that generous introduction. I'm Dr. Alistair Martin, and as Matthew mentioned, I helped to start a program called Get Waivered about 5 or 6 years ago now. And it was aimed at trying to convert our nation's emergency departments into the front door for addiction treatment by helping providers get their DEAX waivers, which allow them to prescribe buprenorphine, which is a medication that can be helpful for folks looking to get into long-term recovery. So excited to be kicking off today's incredible panel here, focusing on the stigma in the healthcare setting. Today, we're going to be discussing how stigma of substance use disorders permeates into and through the healthcare setting. And we're going to be identifying stigmatizing actions, behaviors, language that exists within healthcare settings that hold us back, that serve as barriers for us to truly take care of patients in the way that they should be. I want to introduce my co-moderator, Matthew Stefanko, who you just heard from. He's the director of the National Stigma Initiative here at Shatterproof. And we are going to be leading a panel discussion with some incredible panelists. This is a little bit like the Avengers of opioid addiction treatment coming together here, and I'm so excited to introduce them to you. Why don't we start off with Bill Kinkle, who is a nurse, trained EMT provider, and also the founder of Health Professionals in Recovery. Bill, tell us about yourself. Tell us about your work, how you do it, and what you're up to nowadays.
Excuse me, those are interesting questions. So thanks for the invite and being a part of this panel. It's a great honor. It's great to actually put faces, to some of the names. But yeah, my work's my life has been a strange trajectory. And if you would have asked me at 17 if this is where I'd be, I would have said I wouldn't have believed you. But yeah, I started my career early as a paramedic at 19. And then eventually became a nurse in my mid-20s. Primarily, I worked in the emergency department at the University of Pennsylvania. That's where I spent the majority of my career until about 2008, 2009. I developed an opioid use disorder, or a substance use disorder, which really caused my career to come to a screeching halt. It's something I did not see coming. And that's really where my interest in this issue comes from. But over the past 10, 11 years or so, I've struggled with an opioid use disorder in and out of recovery. I've had periods of long-term 5+ years recovery, 3 years, a couple times here and there. And over, I'd say the past 3 years, about the past 3 to 4 years, I've spent a lot of time in the advocacy space. And one thing that I realized as a healthcare provider is how difficult it was to come out and say, I'm struggling, I'm having a problem. And what I realized is that we have a culture of silence in medicine, that when we struggle, one, I don't think that in medicine, it's commonly known that we actually are susceptible to developing a substance use disorder. I think the majority of healthcare professionals believe that it doesn't happen to us. We go to work, we do our work, we go home, we're strong, and we have this sort of toughness about us. And that's essentially not true. We actually suffer, most likely, we actually suffer more than the general population, but we don't talk about it. And so the reason that we started Health Professionals in Recovery, myself and my partner, Sean Fogler, who's also a physician in recovery, we wanted to try to break down the stigma and break down the walls and to create a place where people who are nurses, physicians, paramedics who struggle with substance use disorders can come and talk about their struggles openly without having any fear or feeling stigmatized. Because when I was a nurse working in the ER, yeah, I was silent. I didn't tell anybody. And that ultimately led to, in that initial phase, a 3-year period where I eventually lost my job, my career, my house, my license. I was homeless for 3 years. I was spent about 6 months incarcerated for a drug-related offense where I was subsequently raped. And so all these things could have been avoided had there been a culture in medicine where I went to my manager and said, "Hey, I'm struggling with drugs." And they said, "That's okay. We have a place to go. Come on, we'll come help you." And so really that's where the focus of my work is to break that down so that we create a culture in medicine where when we struggle, we feel comfortable and confident to say, "I'm having a problem."
So powerful. So powerful. Thank you, Bill, for starting us off. And we look forward to continuing to delve into some of the insights and perspectives that you bring. Such powerful perspective. Thank you, Bill, for being here. I want to introduce Dr. Hector Colon Rivera, who is director of the Asociación Puertorriqueños en Marcha. I want Hector, Dr. Colon Rivera, tell us a little bit about the work that you do. Tell us what you're up to nowadays and how you got into it.
Sure. So I was born and raised in Puerto Rico, right? I'm between San Juan and Vieques. I don't know if you guys are familiar with Vieques. It was like a small island within the island of Puerto Rico. It's part of Puerto Rico. It became famous after the Navy left the island after 60 years of bombarding the island. So imagine growing up in a place that 2/3 belongs to the Navy, and you couldn't go to those 2/3 of the land, and only 1/3 of the island was the community, right? So you're living on that 1/3 of the island. Our cancer rates were super high. Right now, 2021, there's no hospital on the island, and only the primary care physicians take care of the mental health, the substance use disorders on that island. There's one high school and a lot of alcohol-related disorders and opioid-related disorder, but no one to treat it, right? People have to take a ferry and drive over 80-something miles by land and sea to get treatment in San Juan, which is the capital of Puerto Rico. So I was born and raised in Puerto Rico and then moved to do my residency in Boston. Right now, I'm the medical director for APM. We cover most of the social determinants of health. He is here in Philadelphia, Northeast Philadelphia. We treat African Americans, Hispanic communities. That's about 85% of our patients. We have 2 clinics for substance use disorders. We have and 3 clinics for mental health. I'm a board certified psychiatry. My board certifications are in addiction medicine, addiction psychiatry, and adolescent psychiatry. And that's what we do. I start seeing patients from the age of 10 to, I think my oldest patient is like 105, pretty strong man for his age. So in terms of our community and what we do in the community, we have affordable housing. So we have a Department of Housing. We work with the state, giving grants to patients so they get a waiver. If they're homeless, we have shelters, and then we provide housing after that. We have a few schools in Philadelphia, so we have education departments. We have a foster home with over 300 kids that have no parents or have lost their parents due to trauma or other circumstances or substance use. And we have a department that, take care of grants and money and it works as a credit union for our patients. I also work for University of Pittsburgh doing research in access to MAT, medication for assisted treatment for opioid disorder in rural areas. As you know, 90-something% of the PCP, primary care physicians, are in urban areas. So rural areas are left behind, especially in Pennsylvania, which is a huge state. And between Philadelphia and Pittsburgh, it's like seven hours of sometimes no treatment. So what we do is we do research, we apply some apps, technology, we do telemedicine for those rural areas, trying to expand the use of MAT. Access, as Bill mentioned, and someone that understand, right, not only your language, right, but also the culture, the tradition is needed. Someone that opened that door for you at any time, anywhere. So that's what we do at UPMC. I'm a consultant for SAMHSA, here in Pennsylvania, and for AMSCA, which is kind of the synonym of SAMHSA for Puerto Rico. So that's a little bit of what I do, and I'm happy to be here. Thank you for the invitation.
Incredibly comprehensive program, and we're looking forward to hearing more about that, Dr. Colon Rivera. I'm going to now hand it back over to my co-moderator, Matthew, who's going to continue introducing the rest of our panelists.
Thanks, Dr. Martin, and really appreciate you making the time. I know you have quite a busy day today. I'll next introduce Dr. Hadlin. We have two more speakers, and then we'll move into a question and answer. So Dr. Hadlin is an associate professor of pediatrics and a pediatrician and addiction specialist at Boston Medical Center and the Boston University School of Medicine. We've done a lot of amazing work with Boston Medical Center, so we're so happy for you to be here. Would love to just a little bit understand your background. Of course, you're bringing a unique perspective as a pediatrician as well. So would welcome a few minutes of your remarks. Thanks.
Yeah, thanks so much. It's really an honor to be here. And thank you, Bill, for sharing your powerful story to get this really set off on the right foot. And Hector for helping us think through the ways in which stigma can be magnified for certain population subgroups that have traditionally experienced stigma for a lot of other reasons in healthcare settings that really becomes, as I said, amplified when it gets layered on top of the stigma that people experience when they have addiction. The lens I want to bring to this conversation is around stigma that youth experience in healthcare settings. So my background is that I'm a pediatrician. I'm trained in adolescent medicine and in addiction medicine. And so I kind of bring together these topic areas that aren't necessarily commonly sort of brought together. I work clinically in a clinic at Boston Medical Center called the Catalyst Clinic. This is a clinic that takes care of teens and young adults between the ages of about 13 and 25. And we're delivering our addiction treatment here right in primary care. So if you're a young person that has struggles with anything from sort of marijuana, nicotine, alcohol, the more common things that we think of youth using, all the way out to, struggling with stimulants like methamphetamine or cocaine or heroin or fentanyl, we sort of address the full gamut of substances. And we do it in a pediatric primary care environment. And so in coming to our clinic, you not only can get treatment for your addiction from me and from our interdisciplinary team that includes social workers and therapists and psychiatrists, but you can also have your medical healthcare needs met. And that's really critical because we know young people need immunizations. Sometimes young people don't want to go see the doctor, but if that doctor is going to treat their acne, then they're excited to go see the doctor. And that's not just a hypothetical example. I have a number of patients who aren't ready or able to accept treatment for their substance use disorder, but they see me routinely as I treat their acne and make that better. And so it's a little bit of a different treatment model where we're really trying to offer addiction treatment in the same place that young people get all of their medical needs met. And I think actually this has important implications as we think about stigma, because it really is an unfortunate setup of our addiction treatment system that it's so often siloed from other medical treatment settings. And so we're trying to bring things back together to make addiction just another medical and mental health condition that we treat in a patient's medical home by a pediatrician. So I'll be happy to talk a little bit more about that. I think what I would love to bring to the conversation, and I'm happy to discuss more later on in this panel, is thinking about the unique forms of stigma that youth experience. So, we'll spend a lot of time unpacking stigma generally in healthcare settings. We've already touched on some of the stigma that people experience when they are in a healthcare setting and want to share that they have a problem, when they're in a healthcare setting and are considering medications for addiction treatment, which we know often can set people up to experience stigma. But youth experience all of that and then some. And that's because the pediatric workforce traditionally hasn't always, I think, done a very robust job of making sure that young people are treated with respect and dignity when they use substances. And young people also experience a lot of stigma that sometimes can come from trusted adults in their own lives, like family members or community members who may sort of layer on extra layers of stigma that we have to work through. So I'll stop there. I'm happy to discuss these points and others when we get to the discussion.
Great. Thank you so much, Dr. Hadland. And last but certainly not least, I'm excited to introduce Dr. Lagasetti. Shatterproof has been doing some amazing work in Michigan with Michigan Open, and we're so happy to have you here as both a bringing your perspective, but also as a representative of Michigan too. Dr. Lagasetti is a health services researcher and general internist in the Division of General Medicine, and also the Center for Clinical Management and Research at the Ann Arbor VA. She focuses on patients with comorbid pain and substance use disorders. Similar to Dr. Hadland, Dr. Colon Rivera, and Bill Kinkle, I'd love your perspective, your unique perspective, Dr. Lagasetti, with the patients that you're treating, and then we'll move into the broader dialogue. So go ahead.
Great, thanks so much, and I'm honored to be here, especially with so many people that I admire. I would say that I wear a lot of different hats at the institution. I'm currently a researcher, as you mentioned, an assistant professor at the University of Michigan, but I also work as a primary care physician and inpatient attending both in internal medicine and also boarded in addiction medicine. I treat patients that span across the spectrum of having diabetes, having chronic pain, having addiction, and then also, discussing patients that are specifically admitted for addiction-related reasons. And similar to what Dr. Hadland said, I take great pride in the idea that we can offer treatment for patients with addiction, specifically in general medical settings, so that they can potentially be treated in a less stigmatizing environment. But I will say that, one of the things that I really want to focus on today is, a lot of my research really focused on this overlap between, chronic pain and addiction. And it's really led me to kind of really think about how stigma is different for different patient populations. For chronic pain, we often see stigma kind of manifest as disbelief or distrust in people's pain. Doctors may not think that somebody's pain is real or organic or physiologic. We use these types of terms to kind of assign whether pain is, physiologic versus not. For addiction, as we've heard from a lot of our panelists today, there's this idea of, addiction being a moral failing rather than being a chronic disease. And then we have this kind of underlying addiction around substances in general, particularly around opioids. Is it a legitimate therapy? And the recent kind of research has really led a lot of providers to just think that opioids are never recommended. And so all of this stigma around kind of pain, addiction, the substance in general, it's really complex and has, really fortunately led to a lot of decreased healthcare access. And, research by our team has shown that, almost upward of 41% of primary care clinics aren't willing to even schedule an appointment for a person who might need opioid therapy for pain. And if we can't even get our patients in the door, it's hard to screen for substance use disorders. It's hard to address substance use disorders. And so I'd love to talk about that more in the Q&A and really kind of think about how we really need to be kind of thinking about from all of these three different complex perspectives in order to improve healthcare access.
Wonderful. Well, thank you for that. And as everyone attending can tell, we have such a great group with us today. And I know that some questions from the audience are already streaming in. I have a few questions just to get started. And Bill, I'm actually, because you're one of the first speakers, I'm going to start with you. You would have obviously this very unique perspective of both being a provider where you were working with other providers who might have done stigmatizing things or had certain attitudes, and then you've also sort of experienced that yourself, and you mentioned that in the opening. I'd love to hear just that duality a little bit and what it's like from that unique perspective, and how you see just broadly how you're seeing stigma manifest from each side, and what you're seeing out there today.
Sure. Yeah, I mean, it's a really strange place to be. I think the first thing, whenever we talk about stigma, you know, and particularly stigma discrimination surrounding people who use drugs. We really need to acknowledge, especially me being a white male, that stigma and the reason that we hate drug users, it's purely rooted in racism. You know, in the American war on drugs is really where stigma has all began, which has been in pretty much operating in full force for well over a century. And I think just that needs to be acknowledged front and center, that that's really where all this comes from. That the reason that when we look at people who use drugs, we have that certain feeling in our gut of disgust and disdain. And I was taught that way as a paramedic and as a nurse. I was taught that those people weren't really worthy of care, that they did it to themselves. This was purely a moral issue and a choice, and they didn't deserve the same care. And I watched a lot of people be tortured. You know, I watched people who were on long-term methadone maintenance therapy be given Narcan just because people thought it would be funny to watch them suffer and things like that early in my career. This is the early 90s I'm talking. And so I had an opinion about people who use drugs from early on that was very negative. And so when I began to suffer with a substance use disorder, it was really confusing for me because it wasn't an overnight decision. For me, my drug use started with depression, and every time that have struggled with substance use, it's been from severe depression. And my first experience with opioids really came from I had a kidney stone in the early to mid 2000s, and I just remember the first time that I had been given Percocet, that really made me feel. You know, there was euphoria and things like that came with it, but it was really how it made me feel in my place in the world, that I sort of felt normal. I thought, but boy, this is how everybody else must feel normal. I felt very comfortable in a crowd and things like that. And so when I suffered with depression, I pretty quickly found opioids, and I found that they manage my depression much better than any other drug, you know, because when you're prescribed, you know, any type of antidepressant, there's a long period until you get sort of any type of relief, whereas with opioids, it's pretty much instantaneous. But anyway, back to the original question. I found as a healthcare provider, the stigma that I've experienced has been horrific. Because it's not just the general public. The general public hated me, but also my colleagues. You know, it wasn't supposed to happen to us, and I was pretty quickly alienated, not only just with my coworkers, but even, you know, once I admitted to the licensing board that I had this problem, I was put into a monitoring program, which, you know, nursing boards and physician boards, most states have these monitoring programs. And most recently, so I was in a program for about 2.5 years. It was a 3-year program, and I was in the program for 2.5 years. And at 2.5 years is when COVID hit last year, and I was really starting to struggle with just the stress of COVID, the death of multiple friends, the death of family members, a lot of different things. And so I spoke with my addiction medicine doc and told him that I was starting to have some cravings, and I was working in a neighborhood, the neighborhood of Kensington, which is kind of ground zero for drugs in Philly. And we kind of came to the decision that it would be a good idea to start buprenorphine, that would help manage those cravings. And so I started buprenorphine treatment last year. Like I said, I was 2.5 years into this program. I had all negative drug screens. I far exceeded everything that this program recommended. But anyway, when I called the nurse monitoring program through the state of Pennsylvania and told them, said, listen, I'm starting buprenorphine because I think that's the best thing for my recovery, I was immediately discharged from the program because they said that's an addictive drug. And my case manager actually said at one point that, come on, Bill, we know everybody that takes Suboxone, it abuses it anyway. And so I was discharged from the program and told that I would most likely never have a nursing license again. And so I don't just experience stigma from the general population, but I experience it from my own people as well, which makes it even harder. And then to be completely honest, over the past year, that really thrust me into a pretty severe depression. And I had struggled with substance use off and on through the past year, just because for the past 3 years, I had this hope that I would be able to practice as a nurse again, that I would be able to practice as a healthcare professional again, especially with this experience of having suffered with addiction. I thought that I would be able to bring that to the table and be able to take care of patients better. And having had that ripped from me, my dream of being a healthcare professional again, a nurse again, that was devastating to me. And it really made me question just where am I going in life? What do I have if I don't have, what is my identity anymore? And so that's the severity of what can happen and why we need to change. And I think one of the reasons why I talked about it earlier about having a culture of recovery is I think if we did have a culture of recovery and a culture that we suffer too, it would have been easier to ask for help. These monitoring programs would understand that buprenorphine is an acceptable medication just like any other, and it actually would make me a safer provider, a safer professional. And I think we take care of our patients better. And for two reasons. One, like I said, it would make it easier for us to ask for help, but also I think one of the reasons that we do such a poor job of taking care of patients with substance use disorders is because we boot ourselves out. When any one of us suffers with a substance use disorder or mental illness in general, we're kind of alienated from the rest of the crowd. And so there aren't many of us in practice. And so when patients come in, we don't really the people who are at the bedside generally don't understand it. And I'll just finish with, I think it would be extremely powerful if we did allow people who have suffered with substance use disorders at the bedside, because imagine this. Imagine a patient comes in who's just overdosed and their overdoses are reversed with Narcan, and they wake up in the ER, a place where they've been treated like crap every single time they've been there in their entire life. But yet this one time, they wake up and the doc or the nurse walks in, they pull the curtain back and say, hey, listen, I've suffered with opioids myself, or I've suffered with drugs myself, and I've overdosed 8 times myself, but I found recovery and I know what that's like because I've been there. But do you want to talk? Imagine how powerful that could be. And I think that's why we really need to change everything in how we look at just drug use in general, people who use drugs, people who are in recovery, all those things. I think we need to just change everything in the way that we look and think about it.
Yeah, Bill, thank you for that. And I think we heard Dr. Anderson speak, from her perspective this morning, and I think there is so much power in bringing that connection. I'd love to touch, bring in some of the other panelists now. Bill, on one of the points you made really early on in your response, which is around the way that stigma and discrimination is disproportionately influencing individuals from certain racial and demographic backgrounds. And I'd love to hear from the other panelists as well about where are you seeing that overlap manifest? If you have some examples of specific groups. I know Dr. Havlin, you talked about some challenges with youth and others. So I'd just love to open it up to the group to hear a little bit more about that intersection between race, other demographic indicators, and then the stigma of addiction.
I mean, we always talk about positive factors and negative factors when we talk about substance use disorders. And some of the risk factors are, your genes, your biology, where you grew up, right? When we talk about social determinants of health, was it food on your table, right? And I mean, Bill examples is imagine a universe, right, where we have the freedom from discrimination and violence, or we were all socially, our society was inclusive, and there was access to resources. I mean, and we don't have that. We don't have that, especially in communities that are African Americans or Hispanic or Asians in some cases, right? And I mean, I think the story of Bill is so powerful. Even he said that he grew up thinking that people with a substance use disorder didn't deserve better, right? And we don't have that education, and I think we need to start that education from elementary school, or even before elementary school, start at home. So I think that's missing as well. So I think that's where overlap, and people that do not know, don't go through the struggles, are the ones making the decisions.
Yeah, I would add too. There's an intersection here with youth, because I observe that the differential treatment of people of color by our addiction treatment systems starts early. I care for youth starting usually typically around, age 12 or 13. And and there are data to support this, national data and state level data to support this, that when youth of color are using substances or have other sort of mental health or behavioral problems, the approach that they're offered by our systems is typically one centered on punishment, on removal from schools, removal from classrooms, shunting to juvenile, I don't like using the word justice, but juvenile justice systems, I actually think can be quite unjust. Whereas many of my patients who come from quite frankly better neighborhoods, from neighborhoods where the school systems are better resourced, where their neighborhoods are safer, most commonly neighborhoods that are populated mostly by white people and not by people of color, are given opportunities when they use substances or struggle from mental health problems or behavioral problems to see a physician. And so I have families come from far and wide who have resources, who come to see me and get the treatment that a young person should get. But they are most commonly, the folks that are able to overcome those enormous access barriers are commonly not people of color, and people who come from affluent backgrounds and from school systems and areas where they're afforded a lot more opportunities. And this starts at a really young age. This starts right in elementary school, if not earlier.
Yeah, and I would just add that we know that even amongst those who are offered treatment, so those that get through all of these barriers that we've just talked about to even get their foot in the healthcare door, that the treatments vary based off of your race. Our research has shown that, methadone programs are predominantly located in urban, predominantly communities of color. Yet buprenorphine, or Suboxone, which has been around since 2000, while there's been growth in the amount of use of this medication, it's predominantly, only been in white individuals. So even after we account for insurance differences or payment factors such as this, white individuals are almost times as likely to be offered Suboxone. And I don't think that this is, or buprenorphine, I don't think this is by chance. This was, when buprenorphine was initially kind of, less regulated, although we can argue about that, with Data 2000, when they allowed buprenorphine to be used by general practitioners after getting trained. The way that this passed through Congress was, individuals actually made the comment that we should have this other treatment for the suburban user, for the less hardcore suburban user. And, I think we all understand what that code word was for. And so there was racism from the get-go, even around treatments. And so we've got to normalize even our treatment options and make sure that we're kind of being equitable when we're thinking about how we treat our patients, if they even manage to get their foot in the door.
Yeah, Dr. Lagasetti, I think that's such a interesting point, and we've talked a lot about that in our work with stigma, and that there's a lot of exciting efforts that are happening around, anti-stigma campaigns and, better education for providers, and being really smart about who gets that first. And I think we see a lot of times that even though the communities are getting smarter around anti-stigma efforts or anti-discrimination efforts, those first campaigns or those first efforts get pushed to communities that are predominantly white. And so we're years away from those, even, if they're even going to seep into certain communities of color, Black communities, et cetera. We're years away from that. So how do we ensure sort of equitable, distribution of content or training and all these sorts of things? I'd love to, before we get to the audience questions, I have one other topic that I'd love to dig into. And Dr. Lagasetti, I'll start with you, but certainly the other panelists, I'd love your perspective too. As providers, we hear, as at least from the Shatterproof perspective, we hear a lot about from individuals suffering from chronic pain about what happens when you reduce stigma around sort of recovery and how that sort of affects chronic pain patients who then feel like they're not being heard as well. So as providers, how do you think about that balance of making sure that you are, there's a lot on your plate, right? Appropriate prescribing, ensuring that you're providing compassionate care to those with chronic pain, but also compassionate, stigma-free care for those who are, trying to enter into recovery or who are in recovery. So you just talk about that interplay and how you think about it within your work. And then I'd love for the other panelists to jump in as well.
Yeah, this is incredibly complex. I think what's unfortunately happening in the system is that as we are seeing this overlap between stigma on addiction, stigma on pain, stigma around opioids in general happen, when we decrease healthcare access, we decrease prescribing, whatever that may be, even for chronic pain. What it ultimately leads to is a patient with chronic pain will start to make statements such as, I'm not an addict, my pain is real, the hospital was treating me this way. And they're doing this in order to get treatment. They're doing this to have somebody listen to them. But when we make statements like this, we're just further othering those who have addiction, right? And so we're furthering the stigma against those who have addiction, saying I'm not, quote, an addict. And so when we make one system bad, it inadvertently affects the other. And so I feel like, when we're fighting stigma on addiction, it can't operate in its own silo. Right, we have to, we can't similarly just fight stigma and pain. Underlying all of this is just a stigma around the substance, right? And around the use, independent of what your diagnosis is. And so we've got to stop kind of putting one group against the other, because we often know that people have overlapping pain and addiction, and really just start to break down the stigma around the substance use in general, whatever your reason for it is, depression, pain, addiction, you name it. We've got to break it down in its entirety.
I think I agree. This I think has become a really deep divide in medicine and in healthcare, and actually we as healthcare providers have created it. We have created a system that pits one group of patients against another. And this is our fault, and it's on us now to fix it. This is not an either or situation. All of us can treat addiction and treat people with pain, and we can treat everybody just as we were trained to do in medical school and in nursing school, with compassion and dignity and respect. And I think it is rarely the wrong answer to just offer our patients a compassionate ear to listen, to hear what they're concerned about, find out what's bothering them, and address it. And I think a lot of attention is being paid nationally and, in our hospitals across the nation to reducing excessive and unnecessary opioid prescribing. Look, I think that that's important. I think that in the early phases of this national overdose crisis, it's clear that, there are ecological links between rising rates of prescription opioid prescribing and rates of addiction. But we're not in that era anymore. We're in an era in which people are predominantly using heroin and fentanyl, and it's deadly, and we need to be there to treat addiction. And there is, to be very clear, like my read of the data and the read of many others who have read the national data are that when we cut back on opioid prescriptions now in an era in which heroin and fentanyl are readily available, all we do is we drive people who would otherwise use prescription opioids because they may need it for pain to then use harder substances that are more dangerous for them to use. And so I do think it's important for us to be thoughtful in our prescribing of opioids and other medications that can potentially cause problems for people, but it's not the solution to this overdose crisis. And in the meantime, we're losing a lot of people who benefit from opioids, who function better when they receive opioids, be it for acute or chronic pain. And we need to make sure that in our attempts to improve our addiction treatment, that we're not losing those people. They're people that we owe dignity and compassion to. I'll stop there, but I have lots more to say on this. I just don't want to hog it from my fellow panelists.
And this is why it's a great argument for safe supply. I mean, we really do need a safe supply. The contaminated drug supply, what I see in Philly, particularly over the past 2 years, has gotten worse than I have ever seen. And I think that's really why we see the numbers just going skyrocketing of deaths. It's really bad out there. And I think there's a great argument for a safe supply.
Yeah, I would just add that this is not new, right? And this is started back, I mean, it has been forever. It started with the war on drugs from the 70s, then Purdue Pharmacy minimizing the risk of using opioid in the 90s, then the pain mills, right, in the same area. And I mean, we know buprenorphine has been around forever, since the 60s, but as a pain medication, not as a treatment for opioid use disorder. It was known to the 2000s, right? And the data 2000, as Pooya mentioned, that it was allowed to be prescribed in the office space as an MAT for opioid disorder, but it has been around forever. I mean, since the 60s, and for pain management. And this is again part of the stigma. I think that we have to start talking about this educate our kids, but also it's not only the fault of the providers. Yes, we have some fault, but who makes the laws, who makes the advocacy, who is sitting on the Senate? I mean, it's the fault of all of us, right? I think, and that's what stigma is created. I mean, society, and we need to start educating our patients, our people, and society in general. I mean, we need that, all the players.
No, that's great. Really helpful conversation. I'm going to transition to some of the audience questions. We have about 15 minutes left, so hopefully we'll get through as many of these as we can. One that I thought was really interesting, I'm not a healthcare provider myself, but I think, I'm certain that the four of you will have, some strong feedback to this. But one of the questions that was asked was, how do we sort of eliminate and I don't know if stigma is the right word, but sort of judgment or feelings towards providers from other providers who do provide care to those with a substance use disorder. Certainly that's something we think about a lot at Shatterproof, of how can we ensure there's better medical education, more people who are getting into the addiction treatment field. I can't speak to what that might be like from your perspective, but when you are talking to other providers, other clinicians, et cetera, what kind of feedback are you getting about the work that you're specifically doing, especially when I think, Bill, you spoke to this, but when you're sort of pushing the boundaries of what compassionate care should be considered. What are you hearing, and how do you think we can combat that?
I mean, I think we need just an enormously comprehensive education. I think we need to really rethink and redesign from the ground up, really, how we talk about addiction, how we treat it, how we teach about it. From an anti-stigma thing, I mean, people pretty much have been bombarded their entire lives with a negative image of a drug user through media, through television, through magazines, pretty much any way that drug users have been portrayed throughout history. It's been in a negative fashion. So I think in the back of people's minds, we're already programmed to hate this particular subset of the population. And I mean, for well over a century, the way that we treated addiction was through a religious type of means, through prayer and penitence and that type of thing has been, really, I mean, when we talk about treatment, that's pretty much still the if you go into a treatment facility, most treatment places you're going to go to are going to be a 12-step based treatment thing, which ultimately is based on prayer and penitence and doing the right thing and looking at all the harms you've done to people. And that's how we treat addiction still, the majority of the time. And so I think we need to reorganize and teach how we do it. And one of the ways that I think that one of the things that we don't do is we don't teach a good, thorough history of drug policy. And the reason, because the big question for me is when someone comes in and we have that negative feeling about a drug user, where is that coming from? Why do we feel that way? And I think that's one of the reasons is because we've been programmed our whole lives to hate this subset of the population. And a lot of that comes from our policies and just the way that we look at drug users. So I think that's one way that we can deconstruct this. And I think we need to understand, we need to look at also, right now, the one thing you hear is it's a disease, not a choice. And we've created this false dichotomy that it's either or, it's either a disease or it's a choice. It's only one of those two things, when it may be neither. It might not be a disease and it may not be a choice. It might be something completely different. I think there's a lot of trains of thought and a lot of other ideas out there about addiction and what it is. Me personally, I didn't find the disease model helpful in my recovery. I found more like Maya Solovitz's work and Stanton Peele, their work. I found a lot more helpful in the learning model, and that you can outgrow, and that addiction is more rooted in having some type of purpose in your life that you're going towards, and something that makes you happy and feel fulfilled, not necessarily some genetic or some misfunction in my brain. And so I think there's just a whole big, there's just a lot more to addiction than what we think. And I think we need to start teaching people more about it from an earlier age. Like right now, the education that we get in either medical school or nursing school is it's abysmal about addiction. And I think that directly transcends to the bedside of why we do such a poor job in treating people like me. And like I said, over the past year, struggling again with this disorder, I can tell you that we haven't gotten any better. It's still horrific out there, and the treatment that I've received over the past year, by and large, has not been the greatest. The only place I go that I feel safe, and the only place through my entire drug use, the time that I had used drugs my entire life, the only place that I felt safe, where I was treated like a human being and got good, decent, scientific treatment, was the syringe service program in Philadelphia, Prevention Point. That's the only place that I can go or have gone that I've felt treated decently. And that's terrible, that I've suffered with all kinds of illnesses and different things and refused to go to the hospital because I knew how I would be treated, or I was terrified how I'd be treated, that I've suffered kind of in the shadows. And I know hundreds of people who still suffer in the shadows and refuse to go see a physician in a hospital because of how they'll be treated. And I think all that's rooted in how we're trained. So I'll leave it at that.
Hector, Scott, Pooja, any other thoughts?
I would just add to what Bill said about education and medical school and residency. I mean, it was not after the spike on overdoses in 2013, 2012, between 2013 and 2016 that we started caring about adding a curriculum in substance use disorders in school, medical school. We're talking about medical school, right? Future doctors. It was not existent. I mean, Boston Medical Center, addiction was so high, so big in our patient that we were there, right? But we take it outside. I mean, I would say 95% of our programs didn't have that. Before that, addiction medicine was fighting to fill their positions. I mean, addiction psychiatry, they were fighting to get residents because no one was applying. And now it became a hot topic, right? When the problem was always there. So again, I mean, as a society, we're not doing a good job normalizing that what is real, right? And we're only talking about drugs, right? There's behavioral addiction, there's sex addiction, there's gambling, there's other stuff that we're not talking about. And we need to, it happens to people. It happens to good people. It happens to bad people. It happens. And it can happen to you, right? And that's the message we need to be sending.
I think I would just add, I've been fortunate to help, rethink some of the curriculum for the medical students here at University of Michigan. And, when I started to do this, what I found was they were getting a lot of curriculum around opioid prescribing, actually, there was just so much fear around opioid prescribing, which I think, again, was potentially furthering stigma around any opioid use that would, for any patient that would present to the hospital. And so we really tried to rethink the curriculum to be more comprehensive around pain, addiction, stigma, and also talking about some of these policies, such as the war on drugs that's come to play. And I think, we're going to start to change the system. One, we've got to be good role models for when people are starting their medical education or their healthcare training, so that they see examples of people doing this. And, the other thing that I think has really helped us most recently, one of the things that I try to highlight to our students too is, our students are hungry to do something. They want to make the world a better place. They're also, very focused on social determinants and making care more equitable. And one thing that I've really tried to highlight to them now with a lot of the national dialogue around racism too, is that when we don't treat patients, we are essentially sending them to the criminal system, right? So every opportunity missed to not treat a patient in the healthcare system is an opportunity for somebody to be treated in another system. Bill mentioned, whether that's, the criminal system, whether that's like a religiously based system, but these are not the evidence-based systems that we know work. And so we've got to embrace all substance use, whether that be for pain, whether that be for addiction. It's not our job as healthcare providers to deem somebody worthy of treatment or not. We're all worthy of treatment. And so, I think one of these things that we really have to kind of highlight that and roll that at an early stage in somebody's medical training.
Great. Well, we just had one more question come in. I think it's really important. So I know we only have 4 more minutes, so this is going to be, kind of rapid fire on a topic that I'm sure we could do a full panel about. But obviously Bill and others have mentioned the long history of racism and ultimately how we're responding to, providing treatment. And I think a lot of communities of color are responding and saying, okay, great that you're now showing up for us, but you should have been showing up for us for the last 30 years. So like vaccines and so many other things, right? There's this inherent distrust of not just providers, but addiction providers, I think specifically. So when you are saying, okay, now we're here to provide that care, what is that conversation like? Or what are some ways that we can think about, genuinely reaching out with care, recognizing that, frankly, we've dropped the ball for, in a really big way for decades.
I mean, the first step is admitting it, not pretending it's not there. Particularly, like I said in the beginning, me as a white male, I think it's critically important for me to acknowledge that right from the beginning and to be proactive, to be anti-racist from the very beginning. And like I said, we don't have time. I want to leave time for the other panelists, but this is something that I talk about very, very often. I'm very, very open about this and open about the differences between how we handled crack versus opioids. And really, the only reason that we're having this conference right now is because white kids started dying from opioids. Otherwise, this conference would never be happening. And I think we need to admit that.
Yeah, I just would second exactly what you said, Bill. I do find myself confronting it with patients and families. Often in my work with youth, I'm working with families who have experienced addiction over generations. And the approach that we take to young people now is so different from the approach that often their parents, or even in some cases grandparents, experienced when they presented to the medical or other systems with substance use disorders. And I think the most important thing we can do is say, like, hey, we got this wrong for a long time. I really am here right now to try to make this right for you and for us.
I mean, even the focus of this whole thing, pretty much all we've spoken about is opioids, where there are a lot of other drugs other than opioids. Pretty much all we've talked about is buprenorphine, methadone, things that are for opioids. And I think that there's a lot of racism even underlying the discussion that we've just had on this panel, that we really haven't acknowledged that there are other drugs that are a big problem. All we talk about is opioids. And I think that is a big part of the problem too, because it's not just opioids. There's lots of other problems out there.
Yeah, and I think, Bill, you see that, certainly manifesting at the national level in terms of where funding's being allocated. I think we see that a lot with a lot of these, even Shatterproof, right? Like with certain stigma efforts, federal dollars being expressly allocated to do opioid campaigns and not necessarily being allocated for other efforts and campaigns. So it's really interesting, where we see that, where that started, right, with prescription medications and why there's been such a laser focus there. So I am going to wrap up. I think we've identified, probably a dozen topics for next year's summit that we can get into in much more detail. I'm certainly thankful for all of you to join. I hope we have the opportunity to have you back next year, and certainly continuing to engage in this dialogue. I know that Dr. Martin had a lot of perspective that he was hoping to bring and sends his regards, and I think he would have brought a really interesting perspective to this dialogue as well. But I just want to thank all of you for digging into this. I think we know that this is very early work that requires 100 times more work than what we've even discussed today. And so I think just beginning to unpack where the problems lie and where we can get into some of the solutions is so important. So thank you all. The recordings will be available for those who are watching later with transcripts and all of that available. We will be taking a 15-minute break, and then we'll be coming back at 2:15 for another set of 3 different panels. If you want to be joining 2.2, you are in exactly the right place. If you're joining either 2.3 or 2.1, I'll be sad to not see you, but also great options as well. And so come back in about 15 minutes. We'll get started again with another set of panelists. Thank you to everyone who joined today, and really excited to see what's next.
Thanks for having me.
Thank you.